All right, back to it. Any questions from anything we covered last time? We're feeling okay on the material so far in terms of like the kinetics and how we're kind of using these different parameters like our dose and our volume distribution and clearance, all these things, how they're kind of interlocking and interworking with one another. I would assume that silence is a resounding heck yes, we got this. Fantastic. So the next thing I want to get into are some special populations that you're going to be using drugs in, depending on where you work at and kind of who you're going to be seeing. You might be dealing with one of these groups or maybe not, or maybe both in some cases there. So we're talking about pediatrics and geriatrics. Why do we care about these two sort of extremes of age in terms of drugs? Because they are handled extremely differently in either extreme, as we're going to find here, right? One of them, you may find the organs aren't quite developed yet, and that's going to influence how we're dosing things, right? And the other group may find the organs are all failing, and they have to dose it differently because of that, right? So we're going to get into those specifics here in just a little bit. Getting into geriatrics, first off, again, who do we consider to be geriatrics? 65 and older, right? My parents would take great offense at that, but sorry, mom and dad, you are geriatric now, right? And we know that as we're moving on, we're getting a larger and larger population of geriatrics because, again, we're living longer. We have better medical treatment for these things. And so we're going to find that as the boomers continue to move into this phase, you're going to find that we're having a lot of patients you're going to be dealing with. And especially if you're doing primary care, these are going to be like your bread and butter sort of customers here, right? You're going to be running into a lot of these patients. And why do we care about them in terms of drugs? Are they on just a couple drugs? Are they on a lot of drugs? So we're going to talk about polypharmacy and some of the inherent dangers with that, and you're going to find these patients are on a ton of medications, right? We'll talk about some of the issues with that. When you're doing assessments, it's important to figure out, different features, not just like, hey, are you taking your meds right? It gets a little bit more complicated than that. We'll talk about the different points here. But the big thing is to make sure you do good, thorough assessments on these patients, especially the first time you see them, and then also in the follow-ups, you have to make sure you're assessing for changes. I can't tell you how many times I've had patients show up in the ER for a drug, an inadvertent drug overdose because no one went back and actually checked to make sure that patient is still on the right dose of that medication, right? They've been on it for 20 years. It's been working great for 20 years until it didn't, right? Until that organ function changed. Now they're having toxicity, right? So these are things you have to make sure you're kind of assessing on a frequent basis here. And frequently, you want to take advantage of an interdisciplinary group of providers. When I say that, what does that mean? A lot of different people on the team, right? So that means like getting your nutritionist involved, right? It means getting your respiratory therapist involved, your pharmacy, your specialist. You're going to kind of be that little nerve center for all these different providers, because most often if you're working primary care, family practice, like you're going to find that you're kind of that conduit between all these different people, and sometimes you're the one that's going to have to kind of take a step aside and be like, hold on a second, make sure I'm coordinating all these things together to make sure we're taking care of this patient the best that we can, because you'll find that gets complicated, especially as they start to see more and more providers. But everyone has a different perspective. So again, when I'm looking at a patient, I'm assessing for a lot of different things than you might be doing than the nutritionist would. And that's why we try to incorporate all those different disciplines at the same time. Now, getting into looking at the actual function of these elderly patients, we're looking at things like what can they actually do? Like, what is their function? Can they get up and walk around? Can they dress themselves? Can they do the very basics? Sometimes they may not be able to. And then you get into more kind of intermediate to more advanced sort of activities of daily living, right? So, are they out living at the villages and they're getting their golf cart and driving around, going to the grocery store, going to their HOA meetings, yelling at people, like whatever, right? So what can they do and what can they not do? And again, looking for those trends, looking to see like, last time I saw Mrs. Smith, she was able to actually get up and go shower herself, and now she's kind of laid up in bed most of the time. Like what happened, right? What are those changes? Could it be medication related? We'll find out, right? And again, when you're assessing these patients, some of the different features we're going to look into, and this picture's a little dramatic, but again, we'll talk about how that actually influences medicine in a little bit. But starting off with the nutrition section, right? So when you're assessing these patients for their nutrition, what things do you think tend to change with geriatrics in terms of their nutrition? They need more why do they need more protein? So we're going to look at their overall muscle mass for elderly patients, and typically does it go up or down? I mean, you might have some really beefy grandpas out there, but typically, grandpa strength is kind of a thing too. You ever notice like your grandpa's like really strong, even though he doesn't look like it? But typically, muscle mass goes down over time, as we're going to see there. And so, protein intake's important. What else do we care about? Calcium's important, right? We worry about osteoporosis. So again, what are they going to be drinking a lot of potentially? No, that's a huge issue for binding with a lot of medications, right? It binds up other vitamins. It's going to bind up antibiotics in some cases. A lot of issues with that. What else can we see? Well, are they even getting enough adequate intake in the first place, right? Things like serum protein, like albumin, tends to go down when you have a malnourished patient. We've already seen how protein binding can have an effect on drugs, right? Less albumin to a tightly bound drug means that more of it's free, and that free drug does what? Can cause toxicity, right? Maybe the drug works better to a point, but then also toxicity can develop. These are all things we're looking at, right? So again, in looking how the medications are sort of interfacing with these issues here, if we're giving a medication that depresses appetite, that may be leading to their weight loss that you're experiencing there, right? If we have issues where we're giving them medications that worsen their constipation, right? Anyone know any drugs that cause constipation off the top of your head? Yeah, opioids. Yeah, opioid painkillers do it, right? Calcium does it, like we mentioned with the osteoporosis thing. Calcium channel blockers, some antihypertensives can do that. There's a lot of medications that can all exacerbate these issues here, right? So we'll kind of look into some things there, but also like mental status is just a huge thing, right? So again, looking at the medications they're taking, if they're interacting with the foods and maybe intaking or not, can do things like affecting their mental status, right? So these are things we're going to look into. Financial resources are also super, super important. Are they actually able to afford the nutrition that they need? Maybe in a lot of cases they will not be able to. What kind of assistance programs are available? There's Meals on Wheels, etc. Those are things you want to look at. Okay? And can even prepare a meal for themselves, right? Sometimes they may be losing that functionality. Also, even think about things like actual physical dexterity, right? You have someone with rheumatoid arthritis and their joints are starting to become deformed in their hands. They may not be able to actually have the dexterity to make a meal, right? So ask them, kind of get a detailed recall of what they eat, drink, intake within the past 24 hours. So at least get an average kind of what they should be getting in there. You're asking about things like fluid intake. Why do we care about fluid intake? Blood volume, right? Do we want them to make sure that they are well hydrated? Because if they are dehydrated, what organ maybe is not working so well that gets rid of drugs? The kidneys, right? I will tell you that preferentially, what does your body want to perfuse? If it had two organs that had to save out of all the other organs, what's it going to be? Your heart and your head. You can't really survive without those two. I can give you an artificial kidney. I can give you an artificial brain, although most people probably have one in their pocket, right? So in regards to that, when you're dehydrated, because your body wants to perfuse that kind of essential circulation, your kidneys take a hit. And so that means that drugs may not be eliminated, and that can lead to that toxicity, right? So talk about intake of food, drinks, etc. These are all really important things to consider. So going back to the example of warfarin, right? Warfarin, we said, does what? Anticoagulant, right? It's a blood thinner, okay? So one of the big things you'll find with warfarin, if you haven't heard about this, is that it is very dependent on the patient's vitamin K intake, okay? If you have too much vitamin K, and where do you get vitamin K from?
Green vegetables.
Glad no one said bananas. That's K potassium, not vitamin K, right? The green leafy vegetables, right? I always have someone that gets those two confused. That's okay. But getting green leafy vegetables like your collard greens and your kale and your spinach and all kind of stuff has a lot of vitamin K in it. It reduces the effectiveness of warfarin, okay? So I have to give bigger doses to treat this patient than someone who gets very little vitamin K intake, okay? That doesn't mean the patient can't intake any at all. It just means they need to stay consistent with it. And when I was doing my first rotation, when I was in school, coming up on like 10 years ago, it's very scary, very sad. I'm getting so old. But going back to that, I was basically running a Coumadin clinic, right? So again, I would have these patients come in, I would do a little point of care test for their INR, I would talk to them, I'd come up with a dose adjustment, talk to my attending pharmacist, and then come back, and that was their new script essentially. And so it was in Palatka, Florida. Does anyone know where Palatka, Florida is? Yeah. It is at the armpit of nowhere. Like, it is very podunk. These are very salt of the earth kind of people, right? People of the land. A lot of them were growing a lot of their own food, right? They'd be growing their collard greens and their spinach and all this kind of stuff. And so you had to talk to them about their diet, and you had to say, okay, well, what kind of intake are you getting here? Like, are you eating a bunch of spinach salads or nothing, And so you had to make sure you kind of custom tailored their medication regimen specifically to what their diet was. So this stuff does become quite important depending on the medication you're dealing with, right? So again, talking about things like, are there any illnesses that are affecting their food intake? Are they eating fewer than 2 meals per day? That can sometimes have an effect on certain medications in terms of absorption or not. And again, are they getting fruits, veggies, milk, things like that? You want to find out. So to kind of go into further detail here, so you can talk about drinks of beer, liquor, or wine that they're ingesting, right? So you ask somebody, say, how many beers do you have a day? And they say 3. Is that number real? I don't know. Usually they say always double what they tell you they drink or smoke. Why do people not want to be forthright with that? They don't want you to judge them, right? So again, it's a natural sort of feeling there. But again, you can say, well, I had 3 drinks in a week. They're all a whole bottle of wine apiece. Yeah, that's what the size of the drinks too, right? I one time asked a patient who was belligerently drunk. We're trying to figure out if she was intoxicated or anything else. And I was like, well, how many beers do you have? And she said, I only had 3 beers. And I was like, well, how big were the beers? And of course, they're like the gigantic, like almost like 40s practically. And so that makes a difference between that versus like little Bud Limeritas or whatever, So you gotta ask specifics, right? Get into the details here. Ask about dentition issues. Do they have good oral health? Like, do they have dentures, things like that may influence them actually able to intake their medicine or their food. Talk about cost and do they have enough money for those things like that? Do they have any support, right? Anyone around them in the house that can kind of help them, make sure they're getting the nutrition they need. Also, weight's really important to track over time, right? So looking to see if they're gaining or losing could be indicative of their nutrition issues they're dealing with, right? Can even get out of the house to go shop for themselves. So kind of find these things out. So moving more so into the laboratory assessment for these patients, you've covered the majority of kind of basic labs you might get on a patient, correct? Yeah. Good. So these are things you would normally get. So when I say a CMP, what does that stand for? Comprehensive Metabolic Panel, right? So as opposed to what? A basic metabolic panel. What's on a basic metabolic panel? Sodium, potassium, chloride, bicarb. What does bicarb tell us? Acid-base status, right? Tells us they have enough base around to perfectly balance out the pH, right? What else? Well, CO2 is kind of bicarb, right? So you might see them, you'll see them displayed as either, but you're right. Depending on where you work, it'll say HCO3. It might say CO2. Same thing, right? Because again, remember they interconvert. What enzyme does that? Good, carbonic anhydrase. That's important for certain medications, as we'll get into next semester. Anyway, so see all this stuff loops back together. You're starting to think like, man, what's this pharm guy talking about? And then you got Professor Kaplan talking about this. It all links up together, right? Have faith in the process. Anywho, so right, so you have your CO2, then you have what else? BUN, right? Not bun, right? If you want to get laughed off of your rotation, say bun. Your serum creatinine, and that tells us what? Renal function, right? And then what's the last thing? Glucose, right? That's your Chem 7. The comprehensive obviously is going to be more comprehensive, so it'll include things like your magnesium, your phosphorus. It'll also include what else? Liver function tests, right? So ALT, AST, protein, things like that. These are good things to get. If you're, again, seeing a patient for the first time or it's been a while since they've had labs, a CMP is perfectly fine. If I have a patient coming into the ER for an acute problem, probably a BMP is going to be okay for the majority of issues you run into. Just depends. So again, look for changes over time. If I have a patient who shows up in the ER and their creatinine is 2, is 2 high for serum creatinine? That's high, right? 0.8 to 1.2, somewhere around there is typically pretty normal. Lower than that. But it comes in at 2, but I want to know, is that new? Is that new for that patient, or is that an old number for that patient, right? Is that normal for this patient? Because either one could indicate different things to me, okay? So you always want to look for those deltas, those changes over time. Frequently when I'm on call for the poison center and I have someone call and say, hey, the patient's QTC is blah, and I'll say, what was it on the last EKG? It was the exact same. Okay, I'm not as concerned about that than it would be if there was a change, right? Going from there, we have our serum cholesterol lipid panel. Why do we care about that for elderly patients? Because it influences our cardiovascular risk, right? We got to get their lipids under control, otherwise we worry about atherosclerosis and all those other bad things, okay? So we got that. How about A1C? What does that tell us? It's for diabetics. What does it tell us, though? Altogether, no. Average glucose over the past 3 months or so, right? Why do we care about that? Okay, because we have a glucose on the comprehensive. Why do we need something else to tell me? How well they're managing over the long term, right? Because what I'll tell you, you'll have a diabetic patient, you'll get a Chem 7, you'll get a A1C at the same time, and they'll have taken their insulin that day. They're like, oh boy, I got to go see the provider today. I better go take my insulin. They'll take it. Their glucose will look fine, but then you check their A1C. What's a normal A1C? Yeah, 6.5 and less. Usually for diabetics, try to get below 7, but it comes back and A1C is like 9. Okay, we took your insulin today, but you haven't been taking it the last 3 months. That tells you something, right? It tells you something about compliance. You can catch them with that. You'd be like, oh yeah? I think you're being compliant. How do you explain this? And then they're like, I don't know what that number means. And so I'll tell you what it means, buddy. Anyway, So A1C is important for your diabetic patients, right? You can track that over time. Looking at CBC, obviously, we can look for things like anemia. We can look for things like infection, etc. B12 is helpful, again, with the anemic sort of issues. And then urinalysis, occasionally useful. If they're spilling protein or urine. Obviously, they're spilling urine, but they're spilling glucose. Those can indicate different things to us, right? So again, routine labs can be very useful, especially in the first initial assessment and then kind of ongoing to look for those trends. Okay, so getting into polypharmacy, why do we care about polypharmacy? What is polypharmacy? Typically, it's use of 5 or more medications on a consistent basis, right? Why do we have patients on so many meds? They got lots of problems. That could be one thing. Here you got osteoporosis and type 2 diabetes and hypertension and osteoarthritis, and so it adds up pretty quickly, right? And again, multiple disease states might have multiple medications associated with them. People are living longer, more chronic illnesses. I'll tell you, for instance, like patients with HIV, right? If you got diagnosed with HIV back in the 80s, how do you think you're doing nowadays? You're dead, right? Because we had no good treatments for it. However, nowadays, that's the case, right? That's how it was. However, we have better treatments for it now. Now we have patients who are living for decades longer than they were back in the 80s, right? It's only 30 years later, and we're starting to see that they're developing more chronic illnesses, right? Now they're getting diabetes, now they're getting heart disease, all these things that they would never have lived long enough to get because medical therapy has gotten better. So again, that's just one illustration of that point, but it goes for everyone else too. We're living longer, so we're getting more disease states, and that oftentimes may require more medications. And again, looking at evidence-based guidelines, as things change over time, you'll find that may indicate maybe you need to add on more drugs for heart failure, or you may need to add something different in terms of their management for diabetes, etc. Right? So, and again, looking at the number of medications that increase with each disease state, as you see a patient with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and COPD, are those patients uncommon? They're very common, actually. They may be on 12 different medications 5 times a day, right? So do you think it's difficult to keep up with? Absolutely, right? I can't even take a multivitamin every day, and these patients can sometimes keep up with this stuff, which is crazy. So again, based off the guidelines, based off things like hospitalizations, most of the time when you get out of the hospital, you're on more medications than what you started with, okay? So again, the stuff starts to add up. Now again, who do you think is monitoring all these different medications that come in? Patients see their nephrologist, their cardiologist, their rheumatologist, and they come see you for their primary care. Who's managing all that? It needs to be your responsibility, right? So again, and one of the problems you're going to see with this is that if someone else writes an order for a medication and they come to see you, how likely are you to, and you see something wrong with it, how likely are you to change or stop that medication? It's just bad etiquette. You just don't do it, right? However, most of the time, people just don't do anything about it at all. What should you do, though? Call them up, right? Have a talk with them. Be like, hey, I noticed this patient's experiencing this side effect, and I think it's due to this medication. Perhaps we should change the dose. Now you're busy, you're seeing a bunch of patients, you decide, I'll call them later, and guess what? Never happens. This is how you get so many patients on so many medications. Some of them may not be correct. Or patients having a side effect from one drug, and then you decide to prescribe another drug to fix that, and then so on and so forth, right? It's kind of 6 cycle. And again, you think like, oh, you're a pharmacist, it's job security for you if everyone's on drugs. I'd say fewer drugs is better, right? That's why I go to teaching, so I don't have to worry about that stuff. I say fewer drugs is better. So what are the problems? Why do we care if they're on so many meds? A lot of adverse drug reactions, right? If you think about a patient who is taking antihypertensives, right? So on a drug that lowers blood pressure, and they're also on a diuretic, right? Diuretics are going to do what for us? Make you go pee, right? And then you're going to be on, say, something for sleep at night, something that sedates you. Well, imagine you have an elderly patient who gets up in the middle of the night, they're kind of bleary-eyed, they're like, I'll have to go to the bathroom, so bad because of that diuretic I took, and they're stumbling through their room, pitch black. What do you think is going to happen? They're going to fall. What happens when they fall? They break a hip or they break a femur, right? When you have these elderly patients develop these kind of fractures, like it is very bad in terms of morbidity and mortality, right? Oftentimes that is a death sentence for some patients. So because of that, you got to be really careful with this stuff, especially with falls, anything affecting their ability to get around. Decreased compliance is another big issue as well. Again, some people just cannot keep up with these complicated regimens. So again, other reasons for decreased compliance could be just due to the number of medications, the complex dosing schedules. For instance, you have a patient with Parkinson's. One of the things you'll learn about one of the big meds they use for that is called Cinemet, is you have to space it out between meals with protein in it. So oftentimes patients, we actually had some patients here, we were doing a kind of a focus group, we were talking about meds with them, and one of them was like, oh yeah, I have to make sure I get all my protein just in the morning, so I eat my eggs and stuff in the morning to make sure I don't have any interactions with my medicine diet throughout the rest of the day. And it gets complicated, right? That's something that most people don't need to think about, but they do, okay? They have lack of support, mental decline, they don't have the faculties to remember when to take something. Oftentimes they'll take something twice on accident, right? We had a lot of calls at the Poison Center for patients who accidentally took a double dose. Now they're calling and say, well, what do I do? Am I all right? Most of the time, yeah, but sometimes we actually had to send them in because it was a significant enough overdose that it was going to be a problem, okay? Other things like, visual impairment. They can't see the right drug or the dose. Has anyone ever seen like a prescription vial? Is the writing usually like in big, huge letters? It depends, right? But usually no, right? Typically it's a little bit harder to see. I'll always remember this one patient we had when I was on rotations. It was at a community pharmacy, and this lady was coming in. She was just like one of those ones that was filling like 12 different meds, but you could tell she had like the thickest glasses on, and she could not see more than like 6 centimeters in front of her face, right? And I was like, oh my goodness, how do you keep all these medicines straight there? And so she pulls out her old bottles that she had, and she has these different symbols all on the top of her bottles. One would have like a big red triangle, one would have a black circle. And I was like, you keep all your meds figured out by just looking at the symbol and the color? And she was like, yeah, test me. I was like, no way, this lady does not have this together, right? She's like 80 years old, no way. I go through it. She knew every single one of them. She said, oh yeah, that one I take twice a day, this one I take 3 times a day, this one I don't take with meals, etc. And I was like, wow. Her mental faculties were fantastic. It was just the visual impairment that was the big issue there, right? So again, every patient's going to be a little different in that respect. Not all of them will be able to have such an impeccable regimen designed there. Look at things like decreased swallowing capabilities can be problems, especially with things like Parkinson's disease and things like that. Make it very difficult. You may have to change from using, say, tablets over to liquids, or maybe over to patches or something like that, right, to overcome that. IV access can be a really big problem for these patients as well. They're frequent flyers. Oftentimes they develop a lot of scar tissue around those IV sites. They can be very difficult to stick, or if they're especially intravascularly depleted, they're not really tanked up with fluids, you're going to find that's also hard to get IV in those patients as well. So again, these are the problems you run into. Other things though, also willingness to adhere to treatment, right? When do patients say enough is enough, I just don't feel like being treated anymore? That happens, right? Especially towards the end of life, okay? So that's when we start talking about like hospice or palliative care, is when you're not necessarily looking at increasing the quantity of life, but you're more looking at trying to increase the quality of life, okay? So for instance, if I have a patient who's got 6 months to live from whatever disease state they have, and they have mild hypertension, but they get side effects from their blood pressure meds, maybe they just don't want to take the blood pressure meds anymore. If the heart attack gets them early, I doubt it's going to happen, whatever, they'll take that chance, right? These are the conversations you might have to have with these patients in terms of their medical therapy, because sometimes the treatment is going to be worse than just not doing anything about it at all, right? So again, as you're going along, normally we're looking at things to try to increase the extension of life here, right? But obviously we have to transition over to something like palliative treatment at some point. My wife I mentioned is a pharmacist, and she did her second year residency in pain management. You have a lot of these vets and things like that had really severe COPD. They weren't on the transplant list. They were really end of life, right? And they were giving them just mega doses of opioids. Remember, what's the thing that's going to kill someone with an opioid? Respiratory depression. But this COPD was so bad that they were just like, they're just gasping for air, right? That air hunger they had was so severe. But they were like, well, they're giving these mega doses. I'm like, wow, how can you give so much to them? They're like, it just makes them comfortable, right? We don't really care if they're oxygenating that well. They're end of life, like, just make them comfortable. And honestly, that means a lot more to them than trying to get them to live for another couple weeks, right? So again, these are individual conversations you have to have. Okay, so getting into the actual pharmacokinetic changes that occur with these geriatric patients here. So again, cardiac function, do you think goes up or down with age? Probably down, right? How about hepatic function? Probably down, right? How about kidney function? You guessed it right. Everything fails on you, right? The second you turn 30, everything starts failing. So those of you lucky enough to be less than 30, which I imagine is most of you, enjoy it while you can, because time comes for us all. Okay? But look at normal changes that happen here, right? You're looking at things like, higher systolic arterial pressures. You're looking at things like reduced heart rate due to that increased afterload. You're looking at things like, left ventricular function going down, right? So again, this can affect things like getting blood to the places it needs to go, like the liver, right? If I'm deploying less blood to the liver, what happens to metabolism? It can slow down, right? Just like with patients with CHF, that can happen. Renal function is going to go down, and this is really, really important because a lot of drugs get eliminated through the kidneys, and so if they're not being filtered correctly, you're going to find those levels build up and they get toxic very quickly. Okay. Also, acid-base balance is one of the big places that is managed is in the kidneys as well. So if that starts to go out, you can develop some pretty severe acidosis potentially. And again, just kind of looking at this graph here, you can see the normal decrease in function is going to happen. It happens to everyone. It's fairly predictable. So that's why when you see patients, see this in someone who's 60 or 70 or 80, you can kind of gauge, okay, what am I expecting the organ function to be like? And that allows you to kind of more prospectively decide, okay, well, how aggressive do I need to be with this dosing? Do I need to start with this dose or this dose? And you'll get a feel for that as you go through your clinical time. Let's look at other organ changes. Gastrointestinally, you're going to find that not a ton changes. Maybe you have some impaired motility. You see some more constipation. I will tell you, though, the big issue here in terms of drug interactions is going to be drug-drug interactions and drug-food interactions, right? So it's important to make sure that you have things being separated out so that way they're not binding each other up, right? So, for instance, having a calcium can bind to iron, right? They need iron for their hemoglobin, but they also need calcium for their bones. But you got to separate them out because otherwise they chelate together. Anyone know what the term chelate means? Is bind each other up, right? And if they're bound up together, they can't be absorbed essentially, right? Or look at the case. There's a drug called there's a group of drugs used for osteoporosis called bisphosphonates, and they have terrible bioavailability, like sometimes less than 1% bioavailable, right? So they have a really hard time getting absorbed. So when you tell patients how to take it, you have to say you have to sit upright. Take the tablet with only 8 ounces of water. You can't have anything else to eat for at least 30 minutes to an hour. You can't drink anything else, no coffee, no milk, no nothing, just to make sure they absorb something, right? So again, sometimes it can be very labor intensive when they have to take 9 other meds on top of that sometime later, right? Sometimes their whole day is scheduled around when they're taking their medications, right? So it can be very, very difficult. Other things you can find, like with the liver, typically metabolism does tend to slow down a little bit. You're going to find that blood flow, as that decreases, that also will slow the metabolism. That is expected. In terms of absorption, not a lot of changes that happen here, but you will find that this is where you hit those interactions, right? So as an example, if I have dietary changes that maybe are slowing down or speeding up the GI tract, increased use of over-the-counter meds, right? Now again, patients may not always be forthright and tell you about over-the-counter meds because they just maybe don't think of those as meds. So they say, hey, what medications do you take? They'll probably just default to think about prescriptions. You need to make sure you're saying, well, what can you get without a prescription? What do you take like that? And that can also influence, how well of a history you get there. Other things, you can have disease states can actually slow down, impair gastric emptying time. So things like gastroparesis, diabetics, that can impair absorption. So different things that may be a little bit more specific depending on the interaction or the disease state. Other changes that occur. Here's a big one I think is important in terms of drug distribution. So typically what you find in older patients, adipose tissue, you think it goes up or down? Probably goes up, right? What about muscle mass? Unless it's strong grandpa, you're going to find typically muscle mass goes down, or strong grandma, right? Either one. You typically will find that body mass, lean body mass is going to go down. It means muscle mass is down. What about body water? That typically goes down as well, okay? So what does that mean in terms of, say, volume of distribution for a lipophilic medication? It's going to increase, right? It's going to partition out into those tissues there. Maybe that slows down clearance. Maybe that affects drug levels. How about for hydrophilic meds? Volume of distribution go up or down? Tends to go down, right? So you're going to find it be more concentrated, especially when they get dehydrated, right? All that gets concentrated in the serum, and that can extremely affect your volume of distribution, okay? So again, these are changes I want you to kind of keep in mind. Notice as well, things like albumin goes down. What does that do for our distribution? So for drugs that are tightly bound to albumin, if there's less of it there for it to bind to, it gets more free to go out to the tissues. Thus, you can find increased volume of distribution due to that lowered albumin, right? So again, these are little things we're looking at. And again, that's very dependent on things like nutrition status, etc. So these are things we're looking for, okay? Does that kind of make sense? In terms of distribution, it can be different depending on what type of drug you're talking about, lipophilic or hydrophilic, okay? So other things, as I mentioned, protein binding. Again, you may find decreases in serum albumin that affect certain drugs that bind to that, but maybe increases in other proteins. It's it's pretty variable depending on the protein you're dealing with. But again, just remember that if you're saying, for instance, decreasing serum albumin, and you have a drug that's normally tightly bound to that protein, what does that do to the free fraction that's available to interact with the receptors? It increases, right? So not only do you see an increased volume of distribution, but also more drugs at the receptors, so maybe more efficacy, but also more toxicity, right? Again, it's all on the same spectrum there. So again, that free fraction of drug that's available is important to consider. Now, you may not know this, but when you draw, say, a blood level off of a patient, are you getting the stuff that's bound to protein or stuff that's not bound to protein? You're actually getting both. You're getting a total level, and that will actually not differentiate between bound and unbound. In rare cases, you may find you can get a specific free level of a drug, but it is not super common. Just know that sometimes you can have a patient who appears to be either toxic or maybe subtherapeutic, even though the level looks normal, and it could go back to the albumin. Could be that you either have too much or too little, and that's affecting what kind of levels you have there. Okay, again, we'll cover those case-by-case basis in Pharm 1 and 2, and that'll become more clear to you then. Okay, drug clearance in terms of kidney function, we know kidney function is going to go down. However, we said muscle mass also goes down. So what do you think that does in terms of their estimation of kidney function? Well, so what's our surrogate marker that we use for kidney function? We use serum creatinine, right? So we said if we have less muscle mass, what does that do to our serum creatinine? Decreases it, right? So it means I can have like a 90-year-old grandma who weighs like 95 pounds sopping wet, very little lean muscle mass, and she has a creatinine of 0.6. Does that look pretty good? You would think so, just off the number, but do we treat numbers? No, we treat patients, right? So again, linking it back to that patient, I was like, well, of course she has a creatinine of 0.6. I know her kidneys aren't that good. She just has no muscle to actually produce the creatinine in the first place. So those are the things you kind of have to look at it, because otherwise, if I just calculated her her GFR just based off of that singular serum creatinine, would I overestimate or underestimate? I would overestimate what her renal function is. I would dose her too aggressively on those medications, and then I could see that toxicity. Also, what if I had a patient with amputations? Same thing occurs. The creatinine would be falsely low, and then I would overestimate, right? So you have to think about these things and again, link back these labs back to the patient, right? And kind of think, okay, what's the actual clinical situation, right? How do I correlate these together so where I'm not going to accidentally do something goofy and hurt my patient, right? Again, you're going to find that typically you're going to find prolonged half-life of many drugs as renal function goes down. You have to worry about those toxic concentrations for especially those drugs with a narrow therapeutic index. Those are things we worry about. And then again, hydration status is so, so important. I can't tell you how many patients that have come in to the ER, coming from a nursing home, no one's really watching them that closely for the past couple of days, did not realize their PO intake of fluid went down, and that's now dehydrated, that levels have built up, and now they're toxic. You really, really have to watch out for that stuff and make sure they're well hydrated. Of course, there's always caveats with that. If they have renal failure, you can overhydrate them, because then where does fluid like to back up in the body? In the tissues, but then what's the things that could kill them? In the lungs, right? So again, that pulmonary edema that can develop from volume overload, that's potentially life-threatening, right? So again, these are things we think about for these patients. Now again, we talked about the Cockcroft-Gault equation before, and again, I'm not going to have you calculate that on the test specifically, but remember, what does age do to creatinine clearance? As age goes up, creatinine clearance goes down, right? So again, it doesn't matter what the serum creatinine is, that age is always going to be affecting that creatinine clearance. Now again, Cockcroft-Gault's good for most of your like adult sort of patients there. Once they start to get fairly old, more geriatric age, this is where things like the MDRD equation might be a little bit better for them. That's just the kind of study population they were doing it with. But just in general, for most dosing for drugs, Cockcroft-Gault tends to be used the most frequently there. But just know that there's different caveats with these, and some are better for certain age populations than others. Okay, so other factors we can see with this, so I mentioned drug clearance in terms of the liver. Again, this is going to be a lot of it is based off of hepatic blood flow. So as that slowed down, you're going to see slower metabolism of a lot of those drugs there. Not only that, but if you're looking at things like first pass metabolism and bioavailability, think about things like, those phase 1 and phase 2 reactions starting to slow down some. That may do what to first pass effect? It would decrease it, so what does that do to my levels of drugs? It would increase it, right? Because it's not metabolizing as much as it passes through the liver from the GI tract, and thus you may find those levels actually go up there. Not to mention all the myriad drug interactions you can find with CYP enzymes and PGP and things like that, right? So again, those are things to consider in terms of that. It can affect your bioavailability by decreasing that metabolism. So moving more into the pharmacodynamic sort of changes here, are geriatric patients just more sensitive to drugs? No, a lot of it can actually be explained by the pharmacokinetic changes, right? So again, if the volume of distribution is altered to where they're getting much more drug out into the tissues than what they'd bargained for, then yeah, they're going to have more effects from that, right? Or if maybe the renal function's down and they're actually building up a lot more levels of those drugs, those are things you can run into, those problems you see there. But in addition to that, we also find that homeostasis is a little bit more difficult to maintain in these elderly patients, right? So for instance, elderly patients, are they usually hot or cold? I always complain about being cold. That's exactly when I knew my parents were getting old, as I went back home, and I was like, why is the thermostat set at 79? This is ridiculous. I was sweating, and they're like, oh, it's super comfortable here. I was like, oh no. The Grim Reaper's Dark Spectre is falling over my parents' house. This is bad. They're both still alive and they're doing great, but it's just one of those signs, right? You just know it's happening. Other things like their blood pressure, right? When they're going from sitting to standing, you're going to find they don't have as good of an ability to maintain that blood pressure. That's like get that orthostatic hypotension, that dizziness, and that leads to falls, right? The falls is the big thing, right? Fasting blood glucose is going to go up over time. They don't have, again, they develop insulin resistance. All these different things that are going to occur. They just can't really maintain the normal state like a younger patient can. Okay. So let's talk about a few specific drug class examples and how we have to be really careful about using them in this, sort of delicate set of patients here. Has anyone ever heard of the beers list? That is not what you get at the bar. So what craft brews do you have on tap? Right? This is going to be a list of medications that, I think it's Friday, so imagine everyone's going to go home and study and not go to happy hour, right?
Yeah.
Exactly. Thank you. Go pray, study, go to bed. The life of a PA student. Whoever you pray to, I don't care. No, but specifically, the beers list is a list that was developed. I imagine it was a Dr. Beer or somebody, but it was a list of medications you have to be really careful about using in elderly patients because of these changes in dynamics, these changes in kinetics. We know that they're going to be more dangerous in those patients. I'll give you a few examples of those. We'll kind of do this again in Pharm 2 as you're kind of wrapping up your pharmacy curriculum, and we'll talk about the specific agents, but more broadly here, think about things like sedative, hypnotic agents. What do you think we use these for? They're sedatives, we probably use it for sleep, yeah, absolutely. So these are things like your benzos, like your Xanaxes and your Valiums and things like that. We also use them for seizures. We use them for a lot of different purposes, acute anxiety. But again, they all have the same mechanism there. So again, what do you think is a big side effect of a sedative? You get drowsy, you get ataxic, you're stumbling around. Again, the fall risk is the big thing I worry about. Well, with some of those, you're going to find the half-lives can be extended very long in some of these patients here. Either their liver functions slower, so they're not metabolizing as quickly, renal functions down where they're holding it on to it for longer. Not only that, but you can have active metabolites. What do you think an active metabolite is? It's a breakdown product of the drug, but it's still active, right? It still acts the same way as the parent compound. And again, if that does not get cleared through the kidneys because the function is low, then you're going to find that builds up and you see more toxicity. That's why you end up finding these patients seem more sensitive. It's just they can't clear the products as well as a younger patient. So you may have a patient who's coming into the ER with altered mental status and not realize it could be related to the medications that they're taking, right? And these altered kinetics and dynamics there, okay? Other examples like analgesics or opioids specifically, you may find they may be more susceptible to the respiratory depressive effects of opioids, especially when you start to mix and match different sedatives together. You can find they're more sensitive to that, or they can have that accumulation of active metabolites there as well. Morphine specifically has a metabolite that builds up in those patients, and yeah, it helps with analgesia for a longer period of time, but also you can see the sedation, you can see the respiratory depression, etc., associated with that, right? So these are the things you have to consider. Antipsychotics and antidepressants. So lithium, anyone what we use lithium for? I mentioned it before. A bipolar disorder, it's a mood stabilizer essentially. Most of your professors could probably use it, me included. But lithium, it's a small ion. Actually, if you look at it on the periodic table, it's very close to sodium, right? Actually, they're kind of neighbors on the periodic table. And so basically what you find is that the kidneys handle lithium just like it does sodium. So if I have renal dysfunction, I can't get rid of sodium, I also can't get rid of lithium. And so you can find those patients will build up levels, and lithium can be very, very dangerous in overdose. And again, it's not because they just took a bunch because they wanted to end it all. It's because their kidneys just failed out on them and they couldn't get rid of it, and thus they build at that level. Okay, so that can be a big issue there. Antidepressants, a lot of our older agents also really had a lot of fall risk associated with it. Nowadays, in some cases, we have safer agents that we can use for them. So like your SSRIs, like Paxil or Zoloft and things like that tend to be a little bit safer. So if you can, switch them over to something new. That's always going to be more beneficial if you can avoid a lot of those extra side effects. In terms of antihypertensives, the biggest thing is going to be that orthostatic hypotension you can see with that. If you were to dose a patient on a brand new antihypertensive, what do you think the best time of day to do that would be? The morning? When they're up and active, getting up, moving around? Nighttime. Yeah, actually nighttime's a little bit better. So you can start them off at nighttime when they're asleep anyway. They're less likely to be getting up. That can help out with that, right? So again, you can ask them how often you're getting up in the middle of the night. But usually for most antihypertensives, you can start them off at nighttime and avoid some of those issues with that, right? Again, less of an issue for younger patients, but certainly more sensitive geriatric patients, it's a consideration, right? Diuretics, you're going to find all kinds of electrolyte disturbances, hypokalemia, hypomagnesemia, hyponatremia. This can cause a lot of things like arrhythmias to develop. You have to be really careful with that. Yes, ma'am.
So when someone's on a diuretic and they have, you ask them like how much they're peeing throughout the night, are you concerned that they're having too much of like the diuretic, then they're also hypertensive, so are you concerned about like the orthostatic too?
Yeah, you're concerned about it, and we'll find when we actually get into those specific classes that some are going to be more likely to cause it than others, right? So again, looking at the gradation there, with a diuretic, I'm more worried about them having to get up in the middle of the night and tripping over something and falling than I am necessarily about the orthostatic hypotension, just because they tend to have less, because they don't directly work on the vessels, they don't see that as significant of orthostasis, right? Versus if it's something that directly blows open the vessels, that's going to be more likely to see issues there. So yeah, we'll find when we get to the specifics, it'll depend a lot on the patient and the drugs they're using for sure. Yep. Antiarrhythmics, again, you need to be really careful here as well. Just like I might have mentioned this before, but any drug that can treat an arrhythmia can also cause an arrhythmia, right? Just like any drug that can treat a seizure can also cause a seizure, right? So again, we'll get into those details there, but it seems kind of counterintuitive to use something that can cause an arrhythmia, but that's how they treat the arrhythmia, right? So again, if you have poor organ function, you're going to find you don't clear the drugs as well. They're more likely to develop things like life-threatening arrhythmias, your ventricular attacks and VFibs and torsades and all those kinds of things like that. So you got to be really careful with those drugs. Okay. So again, looking at adverse drug reactions, you're going to find that as the number of meds goes up, you're almost guaranteed to find at least one adverse drug reaction. And do patients always know when they're having an adverse drug reaction? Frequently no, right? So unless you actually told them that this is a possible reaction, they're not going to know about it, which is why education is so important, because they may think, oh, well, this is just my body failing. This is just how life is now. And now I realize that, oh, no, there's something you can do about it, right? There could be the dose is too high, or there's an interaction you're not assessing for. And again, consider also over-the-counters and herbal medications. You have to ask about that stuff, because if you miss it, it can be potentially deadly. I'll tell you an example of a patient I had come into the ER for altered mental status and stroke-like symptoms. The patient was on warfarin for atrial fibrillation. She was elderly, and she was worried about her memory going. Does anyone know any herbal supplements you can take for memory? Called ginkgo biloba can actually be used for memory. So she said, well, I'm going to help my memory out. I'm going to take my ginkgo. And either didn't consult with providers and ask anyone anything. And guess what? Ginkgo also has some anticoagulant effects. And guess what the patient had? A massive brain bleed. It's one of those ones where if the pharmacist can look at the CT scan and be like, oh no, it's bad. It was one of those, right? The patient died, unfortunately. So again, herbal supplements, even though they're not regulated by the FDA, they can still be just as effective or dangerous as prescription drugs. So you got to be careful with this stuff. And if you don't ask the question, you may never know, right? So other reasons why we have adverse drug reactions, it could be due to prescriber errors. So again, if you don't take into account changes over time, sometimes patients have been on the same dose of a drug for 10, 20, 30 years. And if you don't go back through and assess, you may miss something, right? Something big in terms of their clearance there. Patient compliance errors, right? As their mental faculties decline, maybe they misheard you and they think they have to take a drug every 4 hours instead of every 6 hours, or twice a day instead of once a day, right? And then, as I mentioned, seeing multiple providers can be very difficult. So the cardiologist is writing for one drug, and neurologist is writing for other drugs. They don't communicate together, and so this is where you run into those problems. Now, depending on the system where you work at, it's nice over at Nemours because our patients come, they see all their specialists underneath the same umbrella, and so everything is linked together. We see everything, which is really good. Most places don't have that, right? So you, being that primary care person potentially, has to be the one that kind of looks at everything and say, okay, well, where are the interventions I need to make here? Do I need to call this person to adjust this dose or get rid of this drug? Is one drug being used to treat the side effect of another? These are things you're going to be looking for, right? Other things as well, patients may not actually recognize drug products as actual medicine. So has anyone ever heard of BC powders or goodies? What are they? They're for headaches, right? You know, it's for headaches. You know what's in it? Yeah, the patients don't know either, right? So it's a southern thing, I think. I did a straw poll several years in a row, and people like from up north, they never even heard of them before. But basically, BC powders or goodies are these little, they have these little wax paper sachets is the term. It's a kind of a folded bit of wax paper, and it has a powdered drug in it. The patient will put it into their drink, and then they drink it, and they take it for headaches. It's aspirin, okay? I've talked about aspirin before. Aspirin can be quite dangerous if you don't know what you're doing with it. So I had one patient who every time he had chest pain, someone told him, well, take a goodies. He goes, okay, so every time he had chest pain. So he had chest pain multiple times a day, and so he kept taking his aspirin multiple times a day. One day he's like, man, his chest pain is just not going away. I should call 911. So 911 arrives, and they say, have you taken any aspirin today? What does the guy say? No. Nope. And so they go ahead and give him another dose of aspirin. Okay. Then he gets into the ER, and the resident goes, have you taken any aspirin today? The guy says, nope. And so they give him another dose of aspirin. So now, in addition to dealing with an acute coronary syndrome the patient had, we also have to deal with the super therapeutic level of aspirin. You see how this stuff can be problematic, right? So again, ask them, what do you take? Ask them, especially BC powders, this can be especially problematic if they don't know it's even a medication. So this is just one example, but there are others that are out there as well. So when you're doing a history on these patients here, it's always really important to ask open or close-ended questions of your patients. Open. Why open? They talk more. They dialogue with you, right? Instead of just being like, do you take your medications like you're supposed to? They're going to say, yep. Or you can say, how do you take your medications? Right? And that opens up a whole dialogue. They can explain it to you. They can tell you how they do it, their technique, etc. Again, you start open, go close as you need more detailed information, right? So again, what side effects are you experiencing? They may not even recognize things are side effects. What problems are you having right now? Try to link those back to the medications potentially. Is there a reason why you're deviating from not taking their meds? Now, some people, if they're not taking their meds like they're supposed to, and you ask them, are you taking them like you're supposed to? They're going to say, yes. Why? Why would they lie to you? Don't want judgment, right? They don't want that stare of like, I told you to do it this way, right? It's kind of like, dropping a vase or something, breaking it and trying to hide it from your mom. Same kind of shame, right? They don't want to deal with that. So you need to keep a very curious, non-judgmental sort of environment with your patients. Say, hey, it's okay if everyone misses doses. Like, how often do you think you miss a dose, right? And you can explain why that is, right? Maybe it's cost, maybe it's side effect. Who knows what the case is? Okay. Ask about non-prescription drugs, right? Ask about things that are not on their med list. It's important. Are they taking any homeopathic drugs, right? When I say homeopathic, what does that mean? They're a little bit different than herbal supplements. So what's the unique thing about homeopathics? They're extremely dilute. You'll actually learn about it more in your complementary medicine class with Professor Lack, but they're extremely diluted to the point where actually there's very unlikely there's even an atom of the original compound they think is in there anymore. Some people think it works, right? But remember, placebo effect is a thing, okay? I'll concede that herbals are definitely pharmacologically important. Homeopathic, I don't know so much. But ask about this stuff, right? Ask specifically, are they taking anything, that's non-prescription based, anything that is herbal based, things like that, so you can uncover these issues. Why do you think people would take meds that belong to family or friends? I think it's safe, it's cheaper. Greta down the street had pneumonia, a couple months ago. She had her extra Z-Pack, went and took it from her. Stuff happens, right? Could be getting medication from outside of the country. There's issues with that. I've seen some lead exposures potentially because drugs were contaminated. It came from another country. So these are things you have to consider, right? And again, check expiration dates. They could have drugs around that have been expired for a really long time that aren't really that effective anymore. I will tell you more about expiration dates later and how most of them are kind of bunk. But again, ask them just to see, because again, if they're taking stuff from like the 80s, maybe they should update that script, right? Okay, if you're not taking medications independently, who's helping you? Do you have like home health care? Is it a family member, someone like that? And then any kind of dosage systems that they use. Like how do they remember to take their drugs when they're supposed to? Do they use a phone? Do they use some kind of pill minder device? Anything like that. Again, ask about techniques, especially with inhalational therapies. As I mentioned, sometimes physical dexterity is an issue here. So can they still take their meds like they're supposed to? Things like that. So those are the big things you want to kind of ask about. Now, these are the pill minders that you'll see used pretty frequently to help remind patients. Now, me as a toxicologist, I hate these because invariably kids will get into them and they'll just take a couple of different doors open and they'll be like, well, how much of this do they take? I don't know. I don't even know what was in those boxes in the first place. I don't remember Monday or Tuesday if I even took those. If those are empty, it becomes a big problem because I have no idea what the kid actually got into. But they're good for older people to remember when to take their meds. So anyway, remember, there's a lot of obstacles to compliance here, right? So imagine if you're working and all of a sudden you're going out to dinner, this really nice fancy steak place, the drug company's putting on a nice presentation by a very smart doctor, and they're talking about this brand new NSAID. So this drug is going to revolutionize everything. It's the best med ever, a couple $100 a tablet. Or you can treat your patient with like ibuprofen, right? Again, you'll never be unduly influenced by corporations, right? Right? You kids are pretty woke, as it were, right? I trust you. But just remember that, if there's a cheaper alternative, go for it, right? Just because like a drug may be efficacious doesn't mean it's worth the cost if something cheaper is going to work, right? Also look at things like medications with mixed dosing intervals. Try to get everything on the same schedule if you can. Not always possible, but it can be. And then when I say intelligent noncompliance, what does that mean? Yeah, they're deviating from your instructions. They're doing it on purpose. You need to kind of uncover that kind of stuff. So again, are they stretching it out? Are they taking a twice-a-day medication once a day to make it last 2 months? That's intelligent noncompliance. You can try to uncover some of that stuff. And then, of course, can the patient even physically take the drug? Obviously, that's another imperative thing. So any questions on the Jerry's? That's what we call them. Not my favorite patient population, but I do like pediatrics a lot. So take a 10-minute break and we'll come back and talk about them. All right, any questions from the first half with the Jerry's? No? don't know why you guys think that's so funny. It's what we call them. Okay, let's see here. So if elderly woman has a low creatinine level, does that mean we might overestimate their kidney function? Yes, actually one thing that I do, and again I don't work with a ton of geriatric patients anymore, but when I was on rotations and in the medical ICUs and whatnot, we need to have someone like that who's like late 70s, 80s, and I saw like, she's very, maybe like 95, 100 pounds, and saw that she had very low muscle mass, and the creatinine came back 0.6. I would just bump it up to 1. That way it's not an exact measurement, but it allowed me to kind of maybe not overshoot as much, right? So I'm a little bit more conservative in my drug dosing for those kind of patients, because they do tend to react a little bit more severely to those changes there, right? So that's what I do, but again, there's no hard and fast rule for that necessarily. And approximately, what is the greatest number of meds you have seen one person on at a time? Oh, geez, I don't even know. There's been a lot. Because sometimes you can have those like ICU patients. So I remember probably the one that comes to mind most. I had a patient who, she was a PICU patient who had bone marrow transplant after developing, she had leukemia, got a bone marrow transplant. And so she was on several different pressors, so probably like 2 or 3 drugs to try to increase her blood pressure. She was on at least 3 antibiotics to try to prevent infection, because when you have a bone marrow transplant, you have to wipe out all of her white cells, right? So she's immunosuppressed and put in the new cells. So she's on 3 antibiotics, antifungal, antiviral. We had to put her on, you guys have heard of C. diff before? It's a Clostridium difficile. When does that happen? Anyone know? We wipe out the normal gut flora, and then you have C. diff kind of colonize. We had to have her on an oral antibiotic just for that. She was on, what else was she on? She was on several things for graft versus host disease. That's where you put them on an immunosuppressant to prevent the transplant from getting rejected. So she's on 3 or 4 meds for that. Yeah, that's probably the most I've ever seen, if I had to think about it. But yeah, it does. I mean, it could be a dozen plus medications, no problem for some of these patients. So yes, very vague answer to a complicated question, I think. Maybe not. Anyway, so let's get into the pediatrics, pediatric pharmacology here. So why do we care about pediatrics so much in terms of like drug therapy? Like, why is this such an important population to consider? Because they're so little. Is that why?
An old person can still speak for themselves.
Okay.
But a little person.
The children.
Yeah, I guess.
Yeah, so I think we're kind of getting there. Yeah, communication is going to be a big key to this, as you're going to see. But typically what is like these patients, and again, when you're dosing drugs for a neonate, someone who's just been born yesterday, versus someone who is, say, 16 years old, I mean, there's a world of difference in terms of their physiologic development, right? To the point where you're going to find that how frequent we dose a drug is, how big of a dose we give, how often we give it, how the type of drugs we use, it is so different between the different populations there, and they change daily in some cases, right? When you're doing the NICU, you have a kid who's there born yesterday versus someone who's been in there for like a month or two. Physiologically, they're completely different than one another, and you have to take into account those changes, because if you don't, you could really hurt somebody, right? Either you're not treating them effectively, or you're potentially giving them so much drug they can really become a problem there. So there's such a heterogeneous population because it changed so much. So a 3-year-old coming in is going to be vastly different than, say, a 9-year-old versus a 16-year-old. Right. So again, that I don't know if anyone's ever heard this, but they're not just little adults is absolutely true, right? Because again, you're going to find that they change so much as time goes on. We'll kind of get into that. Also, is it easy to do clinical studies in children? You think? Why not? Right, yeah, so it's the ethics behind it, right? So again, you talk about protected patient class, and children are one of them, right? So it's very difficult to do those studies from an ethical standpoint to get all the consents and things like that, to where a lot of the information that we have in terms of drugs for kids is being extrapolated from adult data. And again, we said that you're not little adults, so again, we don't always know every single bit of information that we need to know to treat those patients. So it's a little bit more dicey in terms of like, well, I think this will work. Let's find out, right? And we actually just had a case. We were talking in the Clin Pharm class, right? So our second years, they were someone was like, well, we can't use that drug because it says it's not approved for kids. It's like, yeah, like a lot of drugs we use aren't approved for kids, but we still use it anyway, right? It's an off-label use I was kind of mentioning a couple lecture periods ago. We use it all the time, right? So again, just because something says not for kids less than 2, we still use it all the time, right? And so it's important to make sure we're taking into account these changes to make sure we're treating these kids right. Anyway, so in terms of pediatric lingo, we're going to find the gestational age is their maturity at birth in terms of how many weeks they were cooking in the oven, right? Anyone know what a normal gestation is? At 38 to 42 weeks, somewhere around there, right? And again, it's usually based off the last menstrual period and also based on the physical exam, right? So again, when you do like ultrasounds and stuff, you can measure out the baby and determine roughly, how old it is and whatnot. The postnatal age is just going to be that chronological age after they are born, right? So if you're born yesterday, you're now 1 day old, right? And then post-conceptional is the two put together. I tend to find post-conceptional is not used as frequently for drugs as the other two, but certainly, especially when dealing with a neonatal period, neonatal patients, gestational and postnatal are extremely important to understand. So preterm is considered anything less than 37 weeks. Gestational age, full term again, 37 to 42 roughly, and then post-term is anything greater than 43, right? Mom says, get this thing out of me. Say post-term, right? Now, newborns or neonates are going to be considered the first 28 days of life, right? Now, you may hear people call a NICU kiddo, a neonate, an infant. That's technically true, but you can't call someone past that 28 days a neonate anymore, right? They're no longer a newborn, no longer a neonate. At that point, they're an infant. Infant really kind of refers back to the other 11 months of that first year, okay? So again, what do you think is like the youngest gestational age is viable for life, do you think?
23 weeks.
I've seen a 22 week before, right? It's tough, real tough. 24 is usually even dicey, right? So again, these are very immature little babies coming out there, right? And so you're going to find the organ function is not great in any terms. We'll look at those differences there in a little bit, but again, having a kid that's born at 24 weeks is going to be vastly different than a kid that's born at 38 weeks in terms of just the maturity of organ function, et cetera, how we're dosing things, how often, et cetera. We'll get into that. So toddlers are going to be the 12 to 24 age range there, young child more 2 to 5, older kids 6 to 12, and then adolescents 13 to 17. When do you think we start dosing these kids like more like adult patients? Usually based on their weight, right? So as you'll find, for a lot of drug dosing that we do it on per weight basis, right? So I'll do X milligrams per kilogram, right? Again, do we ever use pounds for dosing? You will never use pounds for dosing. You'll always use kilograms, right? Because that, again, is a source for medication errors if people screw up and don't do the conversions right. How do you convert from pounds to kilograms? Multiply or divide? Oh, great. You just overdosed your patient. They're dying now. They're coding. Now, you take pounds, divide by 2.2. If you want to convert the other way, take kilograms, multiply by 2.2. Okay? But typically, most frequently, you're going to be converting from pounds over to kilograms. Okay? Anywho, once they start to get up to calculated adult doses, do you think we go above that? No, you stop and cap out at the adult doses. That's a good rule of thumb to remember for any pediatric dosing. If you start to get above adult size doses, you should really start to question whether you should keep going or just cap it out there. Most of the time, you're just going to cap it out. Okay? So anyways, look at some of the changes here we're going to be looking at in terms of the pharmacokinetics of these kids here, right? So again, I don't know who picked out this picture, but that is the creepiest looking infant I've ever seen. But the graphs are the thing we're going to be focusing on, right? So we're going to look at things like the changes in metabolic capacity in terms of CYP enzymes that they're producing. We're going to look at things like the changes in their integumentary system, renal function, gastrointestinal function, all of that. Because again, it changes drastically, especially during that first month of life, but definitely during the first few years, as you'll see. So in terms of absorption, kind of going back to what we referred to, talking about Henderson-Hasselbalch and all that stuff, the physiochemical properties of a drug in the formulation are going to be affecting how well it gets absorbed, right? Not just through the GI tract, but also through what other routes can kids absorb stuff? The skin's going to be a big one, right? Did I tell you about the kids are showing positive for THC? That's an example there where due to the thinness of that membrane, remember Fick's law, they have a thin membrane and a high body surface area to their weight, more so than adults, you're going to find they tend to absorb things a lot better. And a lot of it has to do with things like molecular weight, right? So you think lighter or heavier molecules get through? Lighter because they're smaller, so they can get through easier. Particle size, smaller is better there. pH and pKa, which we've already gone through ad nauseum. And then dosage form as well, right? What kind of vehicle are we putting these in? Okay, you'll find that if you put, say, a drug into a more fat-based sort of solution, like say like an ointment or something, it may absorb better than it would be if it was a more water-based substance like a lotion or something. We'll talk about that in dermatology next semester. But again, also look at the anatomical physiologic characteristics of the site of absorption, right? So again, you're going to find that even things like IM absorption changes in the neonate. You're going to find that things like integumentary absorption changes pretty drastically here. So getting into gastric absorption, the two things that determine how well drugs will be absorbed from the GI tract. And right now, we're kind of mainly talking about neonates, but you can kind of extrapolate this out to kind of that first infant year of life. But the gastric acidity and the gastric emptying time. Okay, we've already talked about how gastric acidity can affect how a drug is absorbed. So for instance, a weak acid I were to put it into a more basic solution, would that absorb more easily or have a harder time? Have a harder time, right? Because like dissolves like, so that's not fitting that bill there. So anyways, we'll look at gastric acidity and also the emptying time. When I say gastric emptying time, what does that mean? How quick stuff's moving through the GI tract, right? So again, you're going to find that it's going to vary with these kids as well, as we'll see. Again, very different between infants and adults. So what you find is that the pHs tend to be higher in the gastric solutions in the for these preterm infants. Why do you think that is? A lot of it could be due to decreased blood flow going to the gastrointestinal tract. So again, the cells are not getting really the activity they need to produce the acid. You tend to find that they're just immature. The immaturity of the GI tract is preventing formation of a lot of gastric acids and whatnot. Usually what you're going to find is that as gestational age goes up, also the gastric acid production is going to go up as well, right? So they're going to be more close to what they should be if they're at a full-term age there. Normally gastric pH is around 6 to 8 in a full-term infant for the first couple days. Now we said normally GI tract is the stomach is at what pH? 2, right? Around 2. When it gets in the small intestine, that's where it gets more neutral to basic. But again, the first 3 days, it's actually very close to neutral. Why is that? Because they've been kind of passively absorbing and swallowing some of the amniotic fluid since they've been in mom for the past 9 months or so. Okay, so because of that, you're going to find that as the mom can actually influence some of these things in the first couple of days of life, as we'll see. Typically, you're going to have the highest acid content in the first 1 to 10 days or so, and then it's going to fall off around 10 to 30, and then you should be pretty close to adult levels in terms of gastric acidity by 3 months or so. And remember, acidic drugs, what's that going to do to the absorption early on? Decrease absorption. More basic drugs will have an easier time. They'll have increased absorption there, right? So that can affect, maybe there's certain weak acid drugs that I'm not going to use in the neonatal GI tract because I just know it's not going to absorb that well, right? Things like that. So other things, the gastrointestinal emptying time, typically you're going to find that the GIT is going to be much shorter in infants less than 6 months of age. Those things are going through very quickly. I don't know if any of you have any children or not, or have dealt with young infants, but how often do they poop? A lot. They poop a lot, right? They like 4, 5, 6 times a day. It's a lot of poopy diapers, right? Because their gastrointestinal tract is just sending stuff through so quickly. So what do you think that means for drug absorption? It's less contact time, so you'd expect to see less absorption, okay? That's also really important because, again, how can I give meds to an infant? If I don't want to do oral, what other route could I use? You use rectal, right? So again, if you're having those increased amplitudes, those increased expulsions, you may find that if the suppository gets kicked out before it gets absorbed, the drug's not going to work too well, right? These are things we consider, right? Other things, they have congenital heart disease. Maybe they're not really sending enough blood flow to the GI tract because, again, it's a very vascular sort of area. You're going to find that will decrease activity. GIT is going to go down, right? It takes a longer period of time in order for it to get through there, okay? Type of feeding is going to be important, whether they're getting formula, if they're breastfed, and then also their gestational and postnatal age. Usually should be a little faster if they're closer to the full-term age. So, as I mentioned, shorter transit time is going to decrease that duration of contact there, which means it's going to be less likely to be absorbed very extensively. And that may explain why you'd find different concentrations, even though they're given to the same size kids. It could be related to that GIT being different. Okay, looking at extra-oral drug absorption, it's really anything other than oral we're looking at. So looking at muscular blood flow, it can be fairly reduced in neonates. Up to, by the time you're children, you should have normal kind of adult patterns of blood flow. That's going to be important for which route? IM, yeah, intramuscular, right? So again, we're going to find it's going to be an issue there. We'll look at more in detail. How about mucosal permeability? Very efficient for neonates, going to get better, and then close to adult patterns by the time they're children, right? Skin permeability, very much increase in the neonatal period, and again, it'll decrease close to normal adult patterns by the time they're children. So again, this is about 3 years of age or so. It should be pretty close to adults here. So looking at the intramuscular absorption, this is going to be very dependent on several factors here. So one is going to be the blood perfusion to those areas of injection. So if you see like a little neonatal baby, do they really move around a whole lot? Not typically, right? They may flop around a little bit, but you wrap them up in their little blankets and their little papooses, and then they're good to go. They don't have as good a perfusion there, right? And in fact, why do we wrap up those little babies to keep them warm? They dissipate heat pretty easily, right? Especially you have to put little caps on them, otherwise their head loses a lot of heat there. And so again, that affects that blood flow, right? So not good blood flow, they're not really thermoregulating very well, and that can affect how well they're absorbing the drugs from the muscles there. Also, one of the things I'll the analogies I'll make here for these little kids, these little neonates, is they're essentially just big bags of water. Okay, so you have to consider their volume distribution for hydrophilic medications. It's going to be very much elevated as compared to, say, a toddler versus an adult patient, right? Because they're going to have a lot of extra body water compared to someone's a little bit older than them, okay? So again, it's going to mean that apparent volume distribution is going to be higher. We'll look at some other factors of that in just a little bit. But again, typically ion absorption is going to be a little bit slower. It's not going to be as consistent. It's a little more erratic than in older kids. So as I mentioned, decreased blood flow to the muscles, increased percent of water in there, so increased volume of distribution for many medications, and then they have decreased contraction, so again, that also slows down how that rate of absorption there, okay? Looking at rectal absorption, they have very good bioavailability. So anyone know what kind of common meds we'd use rectally for these kids? Tylenol is going to be one of the big ones, right? So we're giving acetaminophen most frequently for fevers and things like that. So that's probably the most common thing, but also some suppositories for, for a laxative purpose, things like that. But again, because that membrane is so thin and the rectum is very highly vascularized, you see very good bioavailability there, not a lot of first pass effect. Okay, but again, you have to worry about the increased rectal contractions, and if it spits it back out, it's not going to absorb very well. So sometimes you have to hold their little cheek shut for, say a minute or two, allow time to kind of melt and be absorbed. I know it sounds silly, but that's what you have to do in order to get the medication to melt and then actually get absorbed, right? Remember, it comes in like kind of that cocoa butter base. It still has some stability to it, but once you insert it, then it gets up to body temperature, it melts, and then it can absorb the drug, right? What do you always do for a suppository before you give it? We can't warm it up too much because then it'll melt, right? Take off the outer wrapping. Oh my goodness, please take off the outer wrapping. I would not want to be that infant. Anyway, so in terms of getting an IV on an infant, do you think it's easier or difficult? Pretty difficult, right? There's some awesome nurses out there who can work some magic on tiny little veins, but it can be very difficult to get IV access, especially if you have a kid who's like, say, coding and they have the blood pressures is nothing essentially, and it can be very difficult. And so there needs to be some ways we can get around that. So oftentimes when you have, like, say, if you're working in the ER and you have an infant or a neonate coming in who's coding, oftentimes you're going to have an intraosseous injection already in place, right? They'll have an IO in place. Very good for emergent situations because basically their marrow is one big non-compressible vein. So really anyone can get an IV in terms of this if you're using the IO. So very handy if you need to. Otherwise, their veins are very tiny. They're very friable, meaning they can extravasate fairly easily, go outside of the vessels. So it can be very difficult, as you'll see. Okay. Now, that percutaneous absorption, talking about actually absorbing it through the skin, as I mentioned, you're going to find that underdeveloped stratum corneum, right? They don't have calluses and things like that built up. And so based on that, because it's an inverse proportionality here, the thinner the membrane, the more flux we're going to have there. So we're going to absorb stuff pretty well. This is an example of a case where we don't use betadine on infants anymore because they actually can absorb the iodine that's in there. And does anyone know what iodine is important for making? Thyroid hormone. What's interesting is you need at least enough iodine in order to develop thyroid hormone, but too much of it actually shuts down the thyroid hormone production. So these kids are getting hypothyroid from too much iodine being absorbed through the skin there, right? I mentioned that lotion that they were using in that one hospital that had them popping positive for THC. They can absorb a lot of stuff through the skin there, right? Because it's well hydrated, it's very well perfused there, and they have a much larger body surface area for their weight as compared to an adult, right? So because of that, it means you can see things like toxicity potentially because they're absorbing things you don't want them to. As an example, isopropanol. Anyone know what another name for that is?
Alcohol?
Rubbing alcohol, right? It's isopropyl alcohol. So they used to use that as an anti-infectant, and they would actually cause lethargy and hypoglycemia in these kids because they would absorb it. And guess what happens when you absorb alcohol? You get drunk, right? And so the same thing happens to little infants. Again, I don't recommend you do that, right? But because of that, they get hypoglycemic, and that was some of the toxicity you saw from that. Or if they're maybe using antihistamine lotions like diphenhydramine or Benadryl, they were developing anticholinergic side effects and seizures even. So again, this is why it's very careful to use any kind of transdermal medication on these patients here, any topicals. So looking at their volume distribution, we mentioned it's already going to be altered based off of their different body water composition here. But again, looking at this, you see the VD is going to be relating that amount of drug in the body to the serum concentration. So obviously you remember that here by rearranging, normally it's C0 equals dose over VD. Flipping that around, VD equal to that dose over C0. And so again, the dose administered, the initial concentration here. And remember, it's just a theoretical number here that we're using, but it's telling us how well distributed these drugs are getting out into the tissues. So if you're looking at volume of distribution, here, all right. So if you're looking at this graph here, looking at the ages from birth, the first several months to years or so, you're going to see total body water is going to be relatively elevated, as opposed to a little bit later on. Tends to go down once they start to get closer to 1 year of age. You're going to see the extracellular water is also going to be elevated. And then what do you notice about the body fat? Not super high initially, right? So again, they may come out with a bunch of rolls and stuff, but it's probably just mostly water in terms of what those are. They develop that fat tissue as time goes on, right? So looking at this, things that affect that volume distribution for these kids includes that lipid solubility, protein binding, tissue binding. We talked about all these previously. Just remember that there's a lot of different disease states that can affect how that volume distribution will change. So if they are edematous because they're holding on to too much fluid, that's going to increase it for hydrophilic meds. Burns can affect it as well. So lots of different changes here. What's important to know about these newborns is that they should be about 70 to 75% body weight is going to be water, right? So again, a lot of extra body water compared to an adult patient. We also have a lot more extracellular water component as compared to adults. They have less fat tissue and less muscle tissue. So that means for hydrophilic meds, you're going to have to give a bigger dose to get the same serum concentrations as you would for someone who had less body water, more fat, and more muscle, right? Basically, they have a much bigger bucket to fill in terms of these hydrophilic meds than an adult might. Again, while these pictures are hilarious, don't put your kids in little tiny buckets because they'll probably tip it over and then get a head injury on your hands and it's no good. We call it DCF and it's not great. This is not my child, by the way. Found this on Google. So. Anyway, so this is an example. Here's a drug called gentamicin. Anyone know what this is? It's antibiotic. Yeah, we use it for a lot of like gram-negative bugs and whatnot. And just wait till we get to bugs and drugs. You guys are going to love that section. It's everyone's favorite. Anyway, that was me being facetious. Anyway, so gentamicin is a common antibiotic we use. It's very water soluble, right? So it's very hydrophilic. So looking at this, you see the different age groups here. We have neonates, infants, and then adolescents. And notice here the volume distribution, how it changes as they get older. So what do you notice? Starts out pretty high, 0.5 to 0.6 liters per kilogram. Is that a high volume distribution? No, right? And again, that shows you that it's a hydrophilic medication because it's less than 1, but it's much higher than it would be, say, if you got into an adolescent or adult patient, right? 0.5 to 0.6 versus 0.2 to 0.3, right? It's essentially halved by the time you're an adult. So what do I need to do to get the same concentration in the serum if I'm dealing with changes in volume distribution? So VD has changed. I want the same C0, so what do I need to increase? The dose I have to give, right? So looking at this, the dose in terms of milligrams per kilogram per dose, because again, everything in kids for the most part is going to be weight-based dosing. So mg per kilo per dose. For that, I have to give a much bigger dose, right? I have to fill that larger bucket because they have so much extra body water. So for them, I'm giving 4 to 5 milligrams per kilogram. Whereas what would happen if I give that same dose to an adult? Too much, right? They develop toxicity. So again, that's why you have to take into account these age-related differences. And when you're looking at, say, a pediatric dosing, so if you go into UpToDate, you guys remember UpToDate, right? Talked about that. Remember, you can go into and type in a drug, and you can get to what we call lexicon. That's the drug references kind of built into UpToDate. You can look at these different things. You'll find there's specific pediatric dosing, and it'll delineate based off of the gestational age. It'll say what the postnatal age, and it'll tell you specifically how to dose it based on those factors there. And again, if you don't look at this, you dose it incorrectly, you can either, one, not treat the infection if you were to give this low of a dose as the adults would get, or toxicity if you give them too much. So other things we're going to find here as well, decreased plasma proteins and lower protein binding stores. So again, that also will increase that volume of distribution because less of the drug is being bound up there. And also other things that may actually compete for binding sites. So here's a good example of one where bilirubin, right, naturally likes to bind to albumin. And so what you can find is that if you have an interaction here, you can find that certain things can kick it off and displace that bilirubin. And anyone know what color you turn if you have a lot of bilirubin in the blood? Turn yellow, right? You get jaundice. So there's a drug called Rocephin. Heard of that before? Ceftriaxone. You cannot use that in the first 28 days of life. The reason for that is because it competes for the same binding site as bilirubin. It will kick it off, and you can induce jaundice in that child, right? So I have to use other antibiotics, and I just know that for that neonatal population, I cannot use that drug. You got to use something else. Once they're past 28 days and they're generally safe enough to go ahead and use it, no problem, right? Because again, a lot of times these kids have hyperbilirubinemia anyway, so you don't want to exacerbate that. Other examples would be, for instance, the drug phenytoin. It's an anti-epileptic or anti-seizure drug. Is normally 90% protein bound, 10% is free, right? And we said which one is like physiologically active to have this mechanism? The free portion, right? So again, that 10% that's free is going to be able to interact with the receptors there. Well, what happens if I have a decreased amount of protein floating around the blood? More of it's free. That 10% maybe goes to 15 or 20. So what does that do for my efficacy? It may go up, but then what else can it cause? Toxicity, right? So those are the things we're really concerned with there. Okay, so looking at some of the changes here, and you don't have to memorize this entire list, but these are kind of general things you're going to find of these patients here. So again, the big one I think about in terms of drug interactions is going to be plasma albumin. Those can be reduced here in the neonatal period, but by the time they're children, it should be pretty close to adult patterns here. Again, it's a very heterogeneous population, so if you're dealing with a neonate versus, say, a kid that's 6 months old versus a child, again, you have to take these into consideration. Okay, so what about metabolism? We talked about the distribution of these drugs here. What happens in terms of the metabolism? Typically, you're going to find it's going to increase drug metabolism the greater they had time to mature in mom, the greater the gestational age and postnatal age, the more metabolism should be going on. Also, you're going to find that things like changes in hepatic blood flow can affect this. So if they have a congenital heart defect or something that affects flow, that could be a problem here. Also, we're going to look at the changes in the size of the liver based on the size of the patient, the quantity and quality of the enzymes, and also some of the disease states here we're going to run into, right? But also remember, you can always have drug interactions here with either enzyme inducers or inhibitors. So, remember our phase 1 reactions. What are the phase 1 reaction doing?
Like the active form?
So that's a prodrug. Remember, prodrugs are inactive initially, and then we activate it either with a phase 1 or 2 reaction, right? Phase 1 reactions are trying to make it more water soluble. Usually it's removing something or uncovering some sort of functional group. This is where you have your oxidations and hydrolyses and all those other things. Remember, the CYP enzyme system fits into this one, right? CYP P450, cytochrome oxidase P450. So this is one of these phase 1 reactions here. Remember, it can be eliminated from the body after that, or what else can it do? Go to phase 2. What happens in phase 2? We're adding something on, like a sulfate group or a hydroxyl group, something like that. Oh, sorry, methyl group. Anyway, so looking at the CYP P450 system here, we know that this is the most important pathway. And you're going to find that typically for full-term infants is about half of what you would see in an adult patient. So already, what do you know about drug metabolism in these kids? It's going to be slower or better than adults? It's going to be slower because they have less enzymes. What does that do to my levels? They're going to be elevated, right? Because again, the drug's not being metabolized as quickly. So as an example here, and you can see some of these changes as time goes on, but for example, phenytoin, I mentioned that anti-seizure med. So by 1 year of age, the postnatal activity actually increases 2 to 5 times that of an adult. So what does that mean for the adult? The dose I would have to give, say, for a 1-year-old versus an adult? It'd be 2 to 5 times higher because I know they're metabolizing it that much more quickly, so I need to give more drug in order to get the same concentrations, right? So these are things we have to look at. So again, this is very age specific. And so what do you have to do as a patient gets older? You go back and you reassess and you go, okay, well, let's look at the new weight-based dosing. Now there are 2, maybe I need to drop it down a little bit. Now there's 6, I need to drop it down further. You have to go back and reassess these things as time goes on. Okay. Other things like demethylation process is slowed down in the infants. And you can see things like theophylline has a longer half-life. This is a drug we sometimes use for asthma, very severe asthma or COPDs in some cases. Not that you have a lot of neonates with COPD, for sure. Some of them are smokers, but we try to stop that in the hospital. Are babies ever on drugs, though? Why? Their mom was on the drugs, right? What do you call that when a kid's coming out and they start going into withdrawal? Neonatal abstinence syndrome, right? So NAS, if you ever see that, those are babies that were exposed to opioids or cocaine or something like that. They're coming out. Now that they're born, they're not being exposed to it anymore. And guess what? They undergo withdrawal just like parents do, just like mom would. It's very sad when you see that, but it happens, right? So we have to learn ways to treat that and give them means of limiting that. Now, if it's an adult patient, I give them more opioids in order to treat the withdrawal. What do you think I do for that neonate? I do the same thing. We put little kids on methadone all the time, right, in order to treat that opioid addiction and eventually wean them off. But I digress. Anyway, looking at some examples of changes in the CYP enzyme system. For instance, CYP2E1, right after birth, within hours, activity goes up pretty drastically, right? Things like CYP2D6 tend to be detectable a little bit after that. However, 3A4 may not be really that well expressed until maybe the first month or so. And again, it's going to differ, and that's why when you look at drug dosing for neonates, you'll see, okay, for this time frame, I want to dose it this way, for this time frame, this way. A lot of it's taking into account these pharmacokinetic changes here, okay? On the phase 2 reactions, you're going to find this is where we're adding on something, some sort of functional group onto the molecule to make it more water soluble, where it can then be excreted, sulfation, methylation, etc. So some examples, kids actually, when you look at it in terms of toxicity, they can handle a lot more Tylenol than an adult can. So as an example, if I had someone that had overdosed on Tylenol, like an adult patient, I would treat them with the antidote at say 150 milligrams per kilogram. That big of a dose, I'd say, yes, I want to go ahead and treat that. For a pediatric patient, especially like an infant or neonate, I can wait until they get up to 200 milligrams per kilogram. I know that they have much better sulfation pathways than adults do, and they can handle that much more drug before I'd actually need to use the antidote. So again, some of this is very case by case, but you'll learn this stuff as you deal with this population. Other things like epinephrine, well-developed functional pathway at birth, and you may see really no differences potentially in some cases there. Other things like glucuronide conjugation, morphine is underdeveloped at birth. So what do you think is going to happen to the half-life of morphine? It's going to be longer, right? Because again, it's not undergoing that metabolism. It's going to stick around for longer, more effects you're going to see there. This is actually an interesting one here. So one thing you'll learn when dealing with the NICU, if you decide to go into that realm, is that you never want to use multi-dose vials of IV drugs. Multi-dose vials means I can go into it, pull some drug out for one patient, and I can go in later on and pull the drug out for another patient, right? Why can I do that? Well, it's because that's preservatives in it. They keep it sterile and stable. There's one called benzyl alcohol that I cannot use in NICU kiddos because they cannot process it. They can't undergo this glycine conjugation, and so they end up developing the severe metabolic acidosis, and they get this gasping syndrome. This killed some kids before. So because of that, we have to make sure that we don't use multi-dose products, only single-use products that we use for those neonates. Okay, and this is stuff you'll kind of pick up on when you deal with these populations. All right, getting into the excretion here, you're going to find that most drugs tend to get excreted renally, at least to some extent. Looking at renal function, do you think it's diminished from their firstborn or elevated? What do you think? If you had to guess, probably diminished, right? Especially the more immature they are, the more immature those nephrons and all the glomeruli and all that stuff are going to be. And typically you're going to find, especially depending on the blood flow, that renal elimination can be pretty difficult to keep up with. Now remember, we talked about how the volume of distribution really affects our dose. What do you think this is going to be affecting? The dose or the interval, do you think? The interval more likely, right? So you're going to find that because the interval tells me how long I'm giving a body time to get rid of this drug, the lower the renal function is, the longer I'm going to have to wait for that drug to get cleared out of the body. And I'll show you some examples of that in just a few minutes here. But again, look at things like concomitant disease stage. Look at other things like nephrotoxic meds. These are all going to be playing a role in these patients potentially. So looking at GFR in infants, actually very frequently we don't actually calculate what we think the GFR is in neonates and infants because again we find that it's not really going to be that reliable in a lot of cases. You tend to find for the first week that the serum creatinine is actually elevated. Now why do you think that is? We said they have less muscle mass, so why do they have an elevated serum creatinine? You're measuring mom's creatinine, right? So actually, because they have that equilibrium with the mom, you're going to find that's actually elevated. So that would be falsely underestimating what their renal function is if I were to use that. And again, remember, with different age populations, you have to use different formulas. There's specific pediatric ones you have to use. One called the Schwartz equation that we use most frequently. But normally during the first couple of weeks, you're going to see renal function will increase. And you may find that those preterm kids have less GFR. They have less well-functioning kidneys due to the immature quality and quantity of the glomeruli. You're going to find the proximal tubules may not be working as well. And overall, depending on the disease state, may have decreased renal blood flow. So again, less blood flow making to the kidneys, less drugs are getting excreted there. And so instead of just measuring and trying to do an equation to determine what renal function is, what other way did I say we can check for renal function? Again, what do the kidneys produce? Make urine, so I can look for urine output, right? So again, urine output is going to be one of the big ways to actually measure how well the kidneys are functioning, right? How do I measure that? Yeah, you can use wet diapers, if they have a Foley in, whatever the case may be. It's a lot easier to measure for them because again, they're neonates. They can't really fight us too much, right? They're extremely weak. I said they have no muscles, so they do what you say essentially, right? Unless they say go to sleep and they don't listen to you. So looking at these kids here, like looking at term infant being this green line here, this light one is going to be preterm, say less than 2,000 grams, and preterm 1,500 grams. Now you notice when you get the NICU, we're not measuring them in kilograms necessarily. Oftentimes it'll be in grams if you ever see that. Okay, and obviously the more immature you are coming out, probably the lighter you're going to be, right? So again, you get very, very small, tiny kids. I've seen, we have a couple of kiddos recently that I think were like 800 grams or something like that, like very, very tiny little kidney beans. But again, you take care of them best we can. But looking at this, you see that obviously in the beginning, their GFR is going to be better if they're full term, they're more developed. But if you look at these preterm kids, even at 2 weeks out, these kids are still not going to be at the same functional levels a preterm would be at birth, right? Because again, just because you've been alive for 2 weeks doesn't mean that you are functionally developed as as another kid that had more time to cook, essentially, right? So you have to consider them; they're still premature even several weeks after they've been born. Okay, it takes them a lot of time to catch back up. So looking at GFR kind of comparisons here, you can find that by the time they're about 6 months of age or older, they typically are pretty close to adult values there. So renal function is less of a concern unless they have some disease states that's decreasing it. But most of the time by 6 months or so, they're generally pretty good. What does that mean for my half-life though? So the lower the renal function, what does that do to the half-life? The longer the drug's going to be sticking around for, right? So if I'm using my example of gentamicin here, if I have a neonate less than 1 week old, you're going to typically find the half-life is anywhere between 3 to 11.5 hours versus if I go all the way up to an adult, say 1.5 to 3. So looking at that, how often do you think I'd be dosing, say, for a neonate versus an adult? Less often or more often? Less often, right, exactly. So for an example, for an adult patient, traditional dosing for gentamicin is Q8 hours. Every 8 hours you're going to be getting a dose there, right? Versus for a neonate, it starts off at Q24, but maybe Q36, maybe Q48. Okay? Because we know the half-life's longer, we know we have to give them more time to clear that drug out before we give them another dose. You give them too much, then you can see all kinds of problems like ototoxicity, nephrotoxicity, etc. So looking at the secretion and reabsorption that occurs within the renal tubules, typically they're going to be significantly decreased during the first year of life. And again, a lot of it is going to have to do with what kind of blood flow they're going to be getting there, how well they're able to concentrate the urine, and also how well they can help to manage their pH. So looking at getting into the diversity of drug response, we looked at the kinetics of the changes that occur between a neonate to an infant up to a young child. But let's look to see why we had different varying drug response for these kids here. Some of it could be just due to the kinetics. Some of it just be due to the age and the prematurity, etc. But also we can look at things like genetic polymorphisms, right? What do we call that? What's the term we use to look at genetics in terms of pharmacology? Pharmacogenomics, right? So we're not very inventive with these words here. We're just kind of slap terms together. So pharmacogenomics, right? That's where we're looking at things like, okay, well, do they have a polymorphism where they're not producing enough of an enzyme or too much of an enzyme, as the case may be, right? We can also look at a lot of the environmental factors here. So like how is food affecting that? The type of feeding that a child is on can be important here. If there's any kind of other exposures that could be playing a role, right? So as an example, I mentioned this before, but this polymorphism, but now we have more context for this now. So the enzyme CYP2D6 is used to convert codeine over into the active form morphine. It's kind of like a prodrug in that way. Remember, we were talking about how in some cases you're going to find that some kids tend to overexpress this. They have a lot more CYP2D6. So what does that do to the efficacy of codeine? Should go up because I'm converting more of it over. So I got more morphine, got more of that morphine, right? Morphine. You can call it that. It's good, right? That should be a good thing, presumably, correct? Maybe not always, as you'll see. Remember that they can have exaggerated effects. I talked about those cases of kids that were getting tonsillectomies, and they were going into, they had these nice swollen airways, and then you give them this codeine, they would convert a lot of it over into morphine, and then what would happen? Get that respiratory depression. Some kids died because of that. So again, this is why we don't use codeine very often in pediatrics anymore, because it's hard to determine who's going to have that CYP2D6 polymorphism that makes them a really good converter versus someone who's going to be a poor converter, and they wouldn't really get a whole lot of effects out of codeine, right? Again, that's why it has a black box warning on it now. Anyone know what a black box warning is? So it shows right at the top of the monograph, and it's like, those are the big things. If you don't heed these things, and you kill somebody or hurt somebody by doing that, you're not going to have a whole lot of leg to stand on legally because we told you about it. It's a black box, right? Very important. So anyway, so how do we dose medications for our kids? We talked about weight-based dosing. Are there any other ways to do it? I'm asking, so presumably, yes, there are, right? So I shouldn't ask open or closed-ended questions because you say yes or no, and then I don't really get a good dialogue out of you. But looking at age-based dosing regimens, you can see here's an example of, say, codeine, which would be age 2 to 5. You say maybe get 2.5 to 5 milligrams. PO, which means by mouth. Q means and then 4 to 6 hours as needed, right? Okay, well, how about for an older kid, maybe get 5 to 10, or greater than 12, you get 10 to 20. What are some of the downfalls of this? Is every 6-year-old the same size? Definitely not, right? What are we dealing with a lot of kids? Obesity, right? With a childhood obesity epidemic, right? So this is an issue here where it assumes that every kid's going to have the same kinetics, everyone's going to have the same weights, all of that. It's not very specific. It's easy to remember, which is why some providers like this, but it's not going to be very tailored to that individual patient, so we don't do it too frequently. Here's the body weight dosing regimens. These are going to be the more common things we're going to be dealing with, and this is where a lot of the math I'm going to have you guys be practicing comes into play, is actually dosing things for pediatrics. Because when you get out into the real world, especially if you don't work with pediatrics very often, what do you think you feel when you have, say, a kid who's coding right in front of you, and you got to figure out what kind of meds to give them and how much to give? Are you going to feel very safe and calm, cool, and collected? No, you're going to freak the heck out, and you're going to need to figure that out anyway, because that kid's dying right in front of you. Figure it out, right? So it's very stressful inducing, and this is why I try to make you do these calculations quite frequently. Anyway, looking at this, for example, dosing, neonates and infants, 20 to 30 milligrams per kilogram per day divided Q12 hours. Okay. Now notice here how we term this can be very different. So for instance, if I said 20 to 30 milligrams per kilogram per dose, Q12 hours is very different, right? You have to keep your units straight here, because if you goof something up, you're either giving double dose or you're only giving half the dose you need to. Both are big boo-boos, and you want to do that, right? Well, I'll give you some examples of that as we get through and talk about those. Again, normally with adults, it's just flat-based dosing, right? So again, you have much more leeway with adults in terms of it's okay if you under or overshoot for a lot of medications. So I can do between 200 and 500 milligrams Q8, not a big problem. For pediatrics, though, you want to be specific, okay? Because again, they're just a little bit more of a sensitive population. So looking at this, this is the most common dosing scheme being used here. And again, in some cases, kids may have increased med clearance, but those are going to be more on a case-by-case basis. This is probably going to be one of the safest things you're going to do, is just use strict weight-based dosing. Now again, depending on kids that are maybe of extremes of weight, you may find that you tend to over or undercompensate depending on the case. I mean, I've had some 16-year-olds that only weigh like, say 40 or 50 pounds because they have severe developmental issues, and that's just did not ever develop a lot of body mass. On the flip side, I've seen kids that are extremely overweight for their age, and again, we have to be careful because we know the distribution is different for those kids, and if you use a standard dose based on their weight, it just may be too much for them, as the case may be. So again, it's something we know we're going to deal with. Another way we can do this is the body surface area. So this is a way to take into account not only the weight of the patient, but also the height of the patient. So you tend to find, even if you have kids that are on the extremes of either end of weight, you tend to find that by factoring in the height as well, you also tend to mitigate those changes there. So again, this tends to be even more exact way of dosing, but it's not done super frequently. Usually only done for very specific cases. The most common thing I use it for is going to be for chemotherapy for oncology purposes. We always dose in meter square or body surface area for the most part. Okay, so again, just know that this is different than weight-based dosing because it also is influenced by the patient's height. Usually the calculations are a little bit more complicated. You can look those up and just know there's multiple calculations, but just figure out which one your institution is using and just stick with that. Now, why might it be hard to measure the height of a child? Can they even stand still for like 2 seconds? I tried to get my kid to just stand on a scale long enough for it to register, and it was like herding cats. It was just impossible. I was like, just stand there. Step off, step on, step off, step on, jump, jump, jump. I was like, stand still. Wouldn't do it, right? 3-year-olds cannot manage. What about infants? Is that a problem? You gotta put them on the thing and you stretch them out, but sometimes maybe you didn't stretch them out right, or you only got one nurse trying to do it. Maybe you get misreading, right? A few centimeters can make a difference for some of these kids, right? So there's different things, right? If you have spasticity, like a kid with CP, you may not be able to get an accurate height that way. This can be difficult, right? It sounds silly, but it's getting a height may not be the easiest thing in the world. What if the nurse accidentally measured the patient with their shoes on? Okay, it could be a reason for a difference from the last time they came to a visit. They get a growth spurt, or they just sometimes leave their platform shoes on with the little goldfish in the heels, most kids don't have those, but I'm just saying, depending on if they left shoes on or not, you could see some differences there. Okay, so in terms of administering drugs to patients, I don't even know if I have time to cover anything else. I don't have 4 minutes, but let me go ahead and see if there's any questions on the board. Any questions from you guys? And we'll get into drug administration more specifically in the math, all this next time. Anything? Yes, ma'am.
Can you
Mm-hmm.
I guess I didn't really understand the intermittent point that you're trying to make in terms of basic relationship.
Oh my goodness. Didn't hear the point. That's why I record these things. So you can get, I'm just kidding. So point being is that some systems are going to be underperforming when they're first born. Some systems tend to overperform, right? It just depends before they kind of equilibrate out to the adult dosing. So I mentioned the sulfation pathway. That's more of a phase 2, but it tends to be really overexpressed in the first year of life, right? So that's why they're more resistant to overdoses with Tylenol, for instance. For the phase 1 reactions, again, you find that different CYP enzymes will be expressed at different rates depending on kind of where they're at in terms of their age. So not everything is expressed to full extent right when they're born, right? It takes time for this stuff to kind of get up to the adult levels. And so that's kind of the point I was trying to get at there. So again, you have to look for this stuff, and that's why if you look at pediatric dosing, you'll find the different age-based dosings there, because they'll say, okay, for a kid that's less than 6 months old, do this dosing, but for 6 to 12 months, do this dosing. They're taking into account those pharmacokinetic differences, either in excretion, distribution, metabolism, any of that stuff. They've already taken into account for you. But I want you to think as a clinician, not necessarily the numbers behind it all, but to kind of know, like, well, why is that dosing different? Okay, it could be because of the distribution. It could be because of the metabolism, these other factors. Okay, let me see if there's any questions. Sure, someone has put a tangent question on here. Why aren't we on the SI system yet? A lot of old people still around. Although I was talking to a patient one time. Did I tell you about my snake bite patient? I was asking them to try to estimate the length of the snake. There's like an 8-year-old who got bitten by a snake, and I was like, oh, well, what did the snake look like? He's trying to describe it to me, and I said, well, how long was the snake? He's like, I have no idea. I was like, well, we have to measure snakes in inches. Do you know why? And he's like, no. I said, because they got no feet.
Oh, man.
Okay.
That's clean.
Yes. So no other questions. So I will see you guys next time. Have a good weekend.